Well, it's delightful to be here and great to see familiar faces and new faces. Again, I'm Barbara Israel. And I want to start by sharing a little of my background and how that has led me in the path to do the work that I do today. As many of you know, and many of you wouldn't know, I grew up in the South. And I'm old enough to remember seeing separate entrances to movie theaters and water fountains labeled colored. As a child, the first person in my life who was close to me that died was an African-American woman who worked for my family. We used to spend a lot of time together. When she died, I asked my mother why our family doctor didn't save her life. And my mother replied, because she couldn't go to the white hospital that he worked at. She died of a burst appendix. I was 7 years old. While I didn't have a label at the time, I was really shaken by that inequity. And it's been a big part of who I am and why and how I do the work that I do in public health. Here are a few examples from the United States of some inequities that exist today. In looking at this map of life expectancy across the United States, in Maryland's wealthy Montgomery County, people live about 12 years longer than in South Carolina's rural Marlborough County. And in Iowa's Sioux County, people live 15 years longer than in South Dakota's Bennett County, only a few hundred miles away. These differences in life expectancy also appear in much smaller scales. For example, this is a map of the Washington, D.C. subway map. You can go 9 stops west on the Orange Line, I'm sure many of you have done this, and from Metro Center to upscale Falls Church, and find a 10-year gain in life expectancy. And closer to home, we find that the 8-mile trip from Telegraph Road on the west side of Detroit to East Warren Avenue on the east side of the city means almost a 50% increase in cardiovascular mortality rates, which is more than 2 times higher the rates of the United States as a whole. So what does this mean and what can we do about it? So this is a model of factors that contribute to these health inequities. And what this model suggests is that while the individual lifestyle factors and our heredity are important to our health, those items in the middle, that there are also other influences that we're surrounded by, like social networks, like our living and working conditions, and even further out, socioeconomic conditions, the environment, and cultural conditions. Thus, in order to reduce health inequities, we need to address all of these layers. Community-based participatory research, or CBPR, is the approach that I've chosen to use to try to address these health inequities. What I like about CBPR is that it links research to action. Historically, there have been several problems with much of our research. First of all, research has rarely benefited the communities that we've worked with. Communities most affected by health inequities have often been left out of the research process. And all of this has led, understandably, to communities' distrust of and reluctance to participate in research. CBPR has gone a long way in addressing these problems. And here are a couple of the principles of CBPR that show how it works. First of all, CBPR builds on community strengths and resources that are available locally in the community, such as caring networks of social relationships and faith and community-based organizations. This is a photograph of a local community garden in Southwest Detroit. CBPR also balances research and action for mutual benefit through equitable partnerships. So it's about gaining knowledge and using that knowledge to bring about change, but doing that in a way that both community partners and academic partners are involved throughout the process. This photograph is a mini market established by one of our partnerships to bring fresh produce to the local neighborhoods. And this came about as a result of survey data that we collected. The Detroit Community Academic Urban Research Center, or the Detroit URC, is one CBPR partnership that aims to put these principles to practice. The Detroit URC was established in 1995 and involves representatives from 8 community-based organizations, the local health department and integrated care system, and several units on the University of Michigan's campus, as noticed here. The center is directed by a board composed of representatives from each of these partner organizations. Our overarching goal is to foster and support CBPR partnerships aimed at promoting health equity. The center initially started our work in the Lower East Side. Those of you from New York, this is a different Lower East Side. And it's a predominantly African-American community, and also working in Southwest Detroit, which is the area of the city where the largest percentage of Latinos reside, approximately 70% Latino. We are presently working in about 7 neighborhoods in the city of a total of about 15 neighborhoods. So what have been some of our accomplishments of the Detroit URC? We've established 10 CBPR partnerships and engaged in over 30 research projects. We've been able to secure $35 million in federal, state, and foundation grants. And most importantly, these funds go not only to the university, but also to community-based organizations. We've hired over 350 Detroit community members, and we've forged new relationships between the African American and Latino communities. We've increased capacity to impact policy change, and importantly, improved health status. For example, across our programs, we've enrolled over 1,000 participants, and we've improved blood glucose levels for adults with diabetes. And we've reduced children's asthma symptoms and unscheduled medical visits. And we've reduced blood pressure and body mass index for participants in our walking groups. Yet, CBPR does have its challenges. I'm only going to mention a few. It's not for everyone. One of the things we've learned early on, it isn't always a good fit for all of our academic colleagues or all community-based organizations. For example, it's not easy for everyone to share power and control. For another thing, it's an understatement, right? I continually work on that one. For another thing, given the bureaucracies of our institutions, they are often tensions between how the university operates and how the needs of community-based organizations. And not surprisingly, this particularly comes up when we're talking about how and when we distribute money, okay? And it's also a challenge to sustain a partnership and interventions after the initial funding ends. Again, I'm sure many of you have had this experience, but funders want to fund new projects. They don't want to fund long-standing projects. So while all these challenges are real, they can be resolved. So what's next for the Urban Research Center? We are in the process of expanding our community academic research network, which is just a lot of words to mean we want to involve faculty, and we are involving faculty not only at U of M, but also Michigan State and Wayne State, and would welcome others who are interested to join with us in this, as well as other community entities in the city. Network members have a profile on our website that puts out their research interest, and then we try to match community interests and academic interests to develop new CBPR partnerships. I'm never quite sure if my mother would be pleased to hear I'm a matchmaker, because I'm not sure that's what she ever expected of me, but I sort of feel that way sometimes now. We aim to extend our Partnership Development Planning Grant program that provides mini grants to newly forming partnerships to help them get started. And we also are providing training, technical assistance, and mentoring to community entities as well as academic researchers who are interested in CBPR as well as policy advocacy. I talked about growing up in the South. When I go back there now, I no longer see separate drinking fountains or entrances to movie theaters. We have accomplished a lot, but there's still a lot of work that needs to be done if we're going to address health inequities in this country. Universities have an important role to play in this effort through authentic CBPR partnerships with communities. Here's what I've learned and recommendations for accomplishing this. First of all, we have to cultivate cultural humility. While I know how to conduct research, I don't know what it's like to live in the southwest side of Detroit. We have to recognize that we can never be culturally competent in somebody else's culture. Rather, we need to be humble and respectful of the culture of others, to listen and to learn. As researchers, we have to be able to share control in doing this work. It's okay to let somebody else share the driving. You don't have to worry about crashing the car, and you get to see a lot more of the scenery. We need to spend time in the community, not just collecting data and feeding back data, but also attending events of our partner organizations, weddings, funerals, and developing true friendships over time. It's critical to share resources equitably. Depending on the aims of a given project, decide who's in the best position to carry out the task, and then to share the resources accordingly. And we need to support and mentor junior faculty. They are our future for CBPR. I've called this talk Linking Research to Action, but I think Nelson Mandela said it even better. Vision without action is merely dreaming. Action without vision is just passing the time of day. But combine vision with action, and you can change the world. Thank you very much.